Hey everyone, this is Dean with Master Medics. Thanks for checking out today's case. It's kind of the last of our medical mystery cases for the month. This one isn't easy. A lot of you may not have heard of this pathology before, and that's okay. At the time, I hadn't either. This isn't a very common EMS problem. In fact, it's an incredibly rare problem for kind of the entire medical field. So, with that said, this is a real case. However, to make it HIPAA compliant, details have been changed to protect the identity of those involved. But this is real. This is a really weird and rare pathology that I happened to experience when I was working in a 911 truck. So, you and your partner are on the scene of a bicycle accident, kinda. The patient is a 28-year-old female who has been in her usual state of health. She was riding a bike down the street and suddenly had to swerve to avoid a squirrel in the roadway. She then dumped her bike, and at the time, she felt fine. She kind of dusted herself off, she got back to her bike, and she kept riding. However, 10 to 15 ish minutes later, she began feeling just very worse, like much, much worse. She stopped riding her bike at that point and then immediately called 911. So when we arrived, she looked horrible. She was incredibly pale, cool, kind of sweating bullets. She had like cyanosis to her kind of peripheral extremities. She had blue lips. She complained of just really minor right-sided abdominal leg pain. Like it wasn't like 10 on 10 or anything crazy like that. It was like a 2, 3 on 10. She stated the pain was basically right on her right flankish area, where her handlebars hit when she went over them when trying to avoid that squirrel. She didn't hit her head. She was wearing a helmet anyway, and she didn't lose consciousness at any point or anything like that. So your partner gets some vital signs for you, and all of them are red flags. So her heart rate's 168. Her blood pressure is 204 over 118. Respiratory rate is 22 to 30. SpO2 is unreadable. Her respiratory rate kind of fluctuates depending on what she's talking and stuff. Her temp and glucose are both unremarkable. Those were fine. When I say unreadable for the SpO2, her fingertips were so cold and blue, they looked like she'd been outside in the freezing cold. And this was like a beautiful summer day. So you help her into the back of the truck, and kind of over the course of the next few minutes, she develops shortness of breath. And she now has rales bilaterally, and those are new within the last like 2 minutes. She's been more and more anxious, and she's started to develop some like palpitations, a little bit of chest pain, and a headache. So I'm not gonna lie, I was lost. I had absolutely no idea what was going on with this patient. None. Her vitals didn't make sense. She was super tacky, clamped down, etc. But her blood pressure was like super hypertensive, and we took it like a few times. We both auscultated and the non-invasive cuff. She was developing lung issues despite not injuring herself there. They were previously clear. She had no like thoracic injury. It was a complete mess, and ultimately, we assumed she was bleeding, and she had some weird kind of catecholamine surge happening from that. We called it a trauma due to her hitting her abdomen, and then coupled with the, pain, heart rate, etc. And en route, we placed her on an honor breather. We weren't really sure what her oxygen status was, but with the lungs down and stuff like that, we went that route. We did consider CPAP, but ultimately we just stuck with an honor breather. Gave her 100 mics of fentanyl just for the pain, and we started 2 lines. So we took her to our um, local trauma center, right? Not really understanding what was going on with her. At the trauma center, she crumped. She ended up getting intubated for altered mental status and hypoxia, and subsequently coded a couple times. They transfused her a few units of blood. They got her blood pressure like shot right up into the 180s ish, and then again subsequently into the 200s. Her fast was negative, but they were essentially just as confused as we were. They had no clue what was going on either, which I'm not gonna lie made me feel a lot better about the situation because I was lost. So in the CT, they actually got their answer. She had a massive tumor on her right adrenal gland with an encapsulated rupture. So this patient had a previously undiscovered or undiagnosed pheochromocytoma that was injured during her fall and subsequently ruptured. So ultimately, she was taken to the OR and actually ended up surviving this incident remarkably. She received an adrenalectomy on that side, which fixed the massive catecholamine dump with the bleeding. I'm not quite sure of the timeline there, if it was like the next day or something. I think they controlled her blood pressure and kind of let her chill out in the ICU first, and then they did it. Um, I know she ended up crashing in the OR. She ended up being put on ECMO, and then after a prolonged hospital course, she was discharged neurologically intact. So it ended up having actually a good outcome. So let's talk about pheochromocytomas. So let's break down that word quick because many of you probably haven't heard of that. So pheo comes from the Greek word pheos, meaning dusky, and chromo comes from the Greek word meaning color, so chromos. A cytoma is just a cellular tumor. It's kind of the root word. And kind of putting that all together, we have a dusky colored patient and a tumor, which perfectly describes this patient. Although it's actually named for the dusky color the tumor cells acquire when they're stained with something called chromium or chromium salts. But anyway, pheochromocytomas are rare neuroendocrine tumors that arise from something called chromaffin cells of the adrenal medulla, so the middle core of the adrenal gland. So here we have the adrenal glands. They sit right on top of the kidneys, and they're basically little hats that the kidneys wear. There's an adrenal cortex, which is that kind of outside layer, and then you have the medulla inside. And the adrenal glands come up with like a million different hormones, to be honest, but like six major ones. But the big ones we're going to focus on, just for the kind of case of today, is the catecholamines from the medulla. So these little fellows do a lot for us. As I said, they secrete catecholamines, namely epi, norepi, dopamine, and they play a huge role in your fight or flight reactions and kind of your fight or flight response. The catecholamines are made here in the adrenal medulla there, and then pheochromocytoma are tumors that kind of grow out of there. They grow within that medulla, and then kind of the main jam with these guys is they secrete catecholamines themselves. So they're catecholamine secreting tumors. So like when we need an epi dump, we stimulate the adrenal glands to release a bunch of epi and norepi and all that stuff, and then we turn it off. These tumors can kind of have a mind of their own and release it randomly. Usually this is epi and norepi, but technically they can secrete dopamine too. And these tumors are kind of rough. They cause death in at least one third of patients before they're even diagnosed with it, which makes the patient from this call particularly lucky. So the signs and symptoms of pheochromocytomas depends on how the tumor is discovered. Some patients, like this one, are completely asymptomatic, or at least they don't recognize their symptoms for most of their lives, and then suddenly become symptomatic from some form of trigger or something. Many, in fact, are diagnosed incidentally on a CT scan for kind of unrelated complaints. Others, on the other hand, develop hypertensive crises, fatal arrhythmias, ARDS. They have like these paroxysmal headache and hypertensive episodes, and they're just symptomatic the whole time. Um, so you can get some patients who have symptoms intermittently, some don't really know they have it at all, and some have attacks that last anywhere from like 15 to 60 minutes and then kind of subside. So it really all kind of depends. When we talk clinical manifestations, these usually include hypertension, which is present in 81% of patients with a pheochromocytoma, and that can be paroxysmal or sustained. So they can either have hypertension all the time that gets treated with different meds, or paroxysmal, meaning it comes and goes. So like they can have episodes of hypertension. Same thing with headache, 60%, palpitations, 60%, and diaphoresis, 52%. Those four are the big four kind of major manifestations we think about when we start to consider pheochromocytomas and stuff like that. But over half of these patients will have attacks or spells. Some will have anxiety, weakness, fatigue, shortness of breath, tremor, dizziness, chest pain, abdominal pain, etc. The list kind of goes on. The important takeaway is that these complaints are really vague. So, what's actually happening here? What causes all of these issues? So, epi and norepi sit inside these vesicles inside the cells in the adrenal medulla. And when stimulated, the gland releases these hormones and they trigger various receptors throughout the body. Hopefully, you're familiar with some of these receptors. They're the like adrenergic receptors, your standard set, right? So you have alpha 1, alpha 2, beta 1, beta 2, beta 3. Just to kind of review these, alpha 1 is located in the vascular smooth muscle. It causes kind of contraction of that muscle. So vasoconstriction is a big thing. So increases systemic vascular resistance, and these are affected more so by norepi than epi, but they're all affected by both. Some just more so norepi versus epi versus whatever. Alpha 2, these are less known for most of us. We don't really learn about this one a ton. They're also on the vascular smooth muscle and then in the presynaptic neurons as well as some other places. Basically, they inhibit norepi, acetylcholine, and insulin release. Um, Not as important for us in the paramedic realm, which is why you probably may not have heard of those ones. Beta 1, you should be familiar with these guys. They live on the cardiac muscle, but also in the kidney and adipose tissues. And when triggered, they increase cardiac stimulation. So they increase that heart rate and contractility. Um, they also increase the renin release and cause lipolysis and the breakdown of fats and all that stuff. Beta 2, these guys are mostly on bronchial smooth muscle, but kind of also in the skeletal muscle, liver, adipose tissue, etc. Triggering them results in bronchodilation, smooth muscle vasodilation, glyconeogenesis, lipolysis, those types of things. And then beta 3 is in the adipose tissue, and it's mainly a lipolysis thing too. All the beta stuff is more epi than norepi. The alpha stuff's more kind of norepi than epi. So with pheochromocytoma crisis, we get this massive dump of epi and norepi, which triggers these receptors inappropriately, and this results in hypertension, tachycardia, etc. And this puts the patients in a lot of risk for complications of such, right? So, like I mentioned before, but basically these tumors secrete a bunch of epi and norepi into the body, sometimes randomly, sometimes after a trigger. Common triggers for these include basically any manipulation of the mass, trauma, glucagon injection, steroid administration, pregnancy, anesthesia, surgery, biopsy, exercise, bending, lifting, certain other med kind of or meds like decongestions, over the counter meds, amphetamines, cocaine, epi, SSRIs, MAOIs, caffeine, nicotine, etc. There's a whole bunch of different triggers. The big risk, at least where, we usually see these folks emergently, is hypertensive crisis. So pheochromocytomas make up around 0.1 to 0.6% of patients with hypertension. So even with that, it's still a very very rare to discover thing. It causes hypertension in less than 1% of all hypertensive cases. So during hypertensive crisis, patients can develop pulmonary edema like ours did. They can develop confusion, also like our patient kind of, headache like our patient, hemorrhagic stroke, heart failure, dysrhythmias, among a whole bunch of other complications. So what happened to our patient? Basically, she was fine. She was in her usual state of health, but she had this pheochromocytoma growing inside of her that she didn't know about. When she dumped her bike, it caused the trauma to it, whether by direct impact or manipulation or kind of just the shock of falling. We don't really know. And this actually laced the tumor in her case and caused bleeding. But it also activated it and dumped a bunch of catecholamines into her system. Initially, she felt fine. Like 10 minutes later, though, it kind of all caught up to her and she developed, this hypertensive crisis and then resulting pulmonary edema, headache, etc. So, how do we treat this? Honestly, most of the time we don't. 99% of the time, these super rare tumors aren't emergencies. Um, you know, they're found, the patient's brought in for surgical removal. They usually stay in the hospital for like a week prior to it to control their blood pressure and stuff like that. Our role tends to be supportive. Generally, we're not going to know they have it. So if the just kind of going through the ABCs, the patient needs an airway, intubate them very carefully. There may be a role for propofol here as an induction agent. If you want to avoid hypertension and catecholamine release, if you read like anesthesia literature on these things, it's what they recommend as the two drugs. However, anesthesia tends to recommend propofol for like everything anyway. Personally, I would avoid ketamine. You want to avoid hypertension, catecholamine release because you're already dumping a whole bunch of catecholamines. I think that's mostly theory on avoiding ketamine. I don't think it's actually been researched, but I might lean, more towards etomidate because of this. Again, I don't think a ton of research has been done on this topic, but that's just my best guess. So, in patients with edema, heart failure, you can consider things like CPAP or BiPAP. And then from a circulatory perspective, the name of the game is usually blood pressure control. Though it is important to note that not all of these patients are hypertensive. Most of them are, but some of them can actually be hypotensive or normotensive. Like I think it's 10 to 15% or so. You know, they commonly are hypertensive, but not all of them. Depends on underlying conditions, duration of the crisis, subtype of tumor, etc. Essentially, though, these patients are in hypertensive patients, kind of with a catch. So within your scope, you can essentially treat these like any other hypertensive crises. But again, you probably won't know it's a pheochromocytoma, so you would just think it's a hypertensive crisis. So, how do you treat hypertensive crisis? Essentially, you lower the blood pressure, and here's where things get tricky and kind of complicated and potentially dangerous. And not all EMS agencies are going to do this type of thing. Ideally, these patients should get a non-selective alpha blocker, and this is the catch. These is how you treat pheochromocytoma crises, hypertensive crisis. Unlike a standard hypertensive crisis where you might use other drugs, right? The main jam being the hypertension, we want to lower it. The best way to do that is alpha blocking. The main receptor causing the hypertension is that alpha squeezing. It's that vasoconstriction from that alpha receptor being triggered. Um, you know, the usual medication for this, especially in the emergency setting, is phentolamine. I'm willing to bet you don't carry that on your ambulance, though, but it is a non selective alpha blocker. So it gets rid of that alpha, which can normalize the blood pressure. Most people carry beta blockers, though, but you really need to be careful with those. The jam using beta blockers first is that you can get an unopposed alpha stimulation, right? Because we're squeezing both alpha and beta, and if we get rid of that beta, we now have unopposed alpha, which is actually what's causing the crisis for the most part anyway. So you don't want to use beta blockers first. You get that unopposed alpha stimulation response, and that can worsen the hypertension and worsen the condition. So you want to avoid those. Calcium channel blockers, nicardipine or clofidipine and stuff like that, can be used. These are going to be, you know, not generally the primary choice. They usually are kind of added to phentolamine, or they're started first. Like you have this hypertensive crisis patient, you'll start a nicardipine drip. You'll send them to CT, like in the hospital setting, and they'll be like, "Oh crap, it's a pheochromocytoma." Then they'll add phentolamine, stuff like that. But most ambulance services don't carry these either. For EMS, it really is just supportive care, that kind of thing. CPAP for edema, oxygen, IV monitoring, ECGs, look for ischemia, treat the complications of that kind of thing. Generally, EMS isn't in the business of acutely lowering hypertensive emergencies. Some places do it, so it's worth touching on, in my opinion, but generally not. So the goal for hypertensive crisis is to lower the blood pressure relatively slowly. Usually, your goal is to lower it by 20 to 25% in the first hour, and then down to less than 160 over 100 in the next few hours. Here, however, the goal tends to be like in the setting of pheochromocytoma. In hypertensive crisis, in the setting of pheochromocytoma, I should say, the goal tends to be rapid normalization. So there doesn't seem to be a consensus number. I've seen less than 140. I've seen less than 130 thrown around as a goal. But generally, you want to do that within an hour or less. So you kind of rapidly lower these folks as opposed to your standard hypertensive crisis folks. But honestly, this isn't, a treatment talk, right? It's a here's this cool medical mystery rare diagnosis kind of talk. So more of an awareness level. But just so you know, technically you can treat a hypertensive crisis. The ultimate fix is surgery. Usually, this involves a team of surgeons, anesthesiologists, and endocrinologists who are all kind of used to doing this together because they need to work really closely together. And these patients get an adrenalectomy. Ideally, they'll stay in the hospital first, they'll control their blood pressure, and they'll actually go in laparoscopically from the back. However, if it's a bigger tumor, if there's complications, if they're in a crisis, those types of things, they might have to do like an open laparotomy and stuff like that. Um, but usually these patients' blood pressures are controlled for a week or so beforehand. Um, this isn't generally an emergency. It isn't a rushed event. They'll sit in the ICU, get their blood pressure controlled, and then they'll go into surgery. So with that, I strongly encourage all of you to look up pheochromocytomas kind of further on your own. There's way more to know. This was just kind of a quick case study. Just it can't really give it some justice, but just wanted to, give you an awareness level that this thing exists and it's something that we can see. So with that said, thanks for watching. If you have any questions, post them below and I'll try to get back to you over the next couple hours. Sorry I couldn't do this one live, but hope you enjoyed the recording anyway, and see you next time.